Good afternoon. Thanks for joining us at EHJ today. I'm Robert Ye from the Massachusetts General Hospital. I'm joined today by my friends and colleagues Dean Kariakis from Christ Hospital in Cincinnati and the Lindner Research Center, and Roxana Moran from Mount Sinai Hospital. We're here today to talk about the EVOLVE-2 study, for which, Dean, you were the principal investigator. Tell us about why you did this study and what you were evaluating.
EVOLVE-2 is a pivotal trial for U.S. FDA approval of a novel bioabsorbable polymer metal platform coronary stent. And the concept, I think it's been around for a while, is that once drug elution is complete, polymers really have little or no function. And we know that in some of the durable polymers may be associated with late inflammation, may be a nidus for thrombus, or even neoatherosclerosis. And so having a platform where the polymer does its job, gives off the drug, and then goes away might be attractive. This is a new generation bioabsorbable polymer platform. It's an ultra-thin platinum chrome metal strut of about 29,074 microns, upon which is placed a 4-micron thin PLGA polymer on the abdominal surface only. And the drug is everolimus in a dose density of 100 microgram per centimeter squared. And so this novel device, which has been tested in a first in man, was non-inferior for late lumen loss at 6 months by Ian Meredith and Stefan Verhey. This was compared to the Promus Element stent. So non-inferiority at 6 months was proven based on late lumen loss, an angiographic endpoint. This trial was adequately powered to provide a clinical endpoint.
And tell us what you found in the study.
Well, we randomized 1,684 patients 1-to-1 to either the Promus Element Plus as the comparator or the Synergy stent. It's a complex group of patients. Over a third had unstable angina, over a quarter had myocardial infarction during their index hospitalization before PCI, and 75% of the lesions in both groups were B2C, lesion complexity. And in that, we had a TLF estimate of 8%, a non-inferiority margin of 4.4%, and what we found, analyzed by intention to treat and then per protocol, and that was a requirement in order to prove non-inferiority. By intention to treat, 6.7% TLF at 1 year with the Synergy, 6.5% with Promus Element Plus, and per protocol it was 6.4 and 6.4%. I might say this is using a very sensitive definition, a greater than 3-fold bump in CKMB as being a definition of periprocedural MI. So that would always pretty much raise your periprocedural MI, your target vessel related myocardial infarction component of the target lesion failure endpoint. So even with that, it was 6.7 and 6.5 by intention to treat, and 6.4 equally by per protocol analysis. And Bobby, the p-value has 3 zeros in it either way, proving definitively that it's not inferior at this point to the established comparator, which is Promus Element Plus.
Roxana, let me ask you here. We've seen TLF rates declining for the new generation drug-eluting stents. We've seen stent thrombosis declining for those. Do we need a new stent? And tell us how this stent adds to the mix of what we know to be high-performing latest generation everolimus or zotorolimus-eluting drug-eluting stents.
So thank you, Bobby, for the very, very important pointed questions. Do we need more? Have we reached the ceiling? And I would say that we can continue to evolve, as EVOLVE-2 has, and I think that's really where we need to go, and I don't think we'll stop developing the very next best generations as we go along. But Dean and your investigators should be congratulated for actually doing a trial like this, very important trial, to prove non-inferiority with regards to a large composite endpoint of MACE, which is target lesion failure, which is what we're used to. So they achieve that. But it is important to note that these event rates are very low, 6 to 7% event rates. The stent thrombosis rates are extremely low. So if we were to actually design a trial to actually show an improvement on those safety endpoints, safety parameters, you'd need 20,000+ patients. So it's even much more than that. So difficult to achieve that. So I would say come back to the investigators and hopefully to the sponsors to say, can we, and you may not like this one, but can we evolve to a shorter duration of dual antiplatelet therapy for stent-related complications so that we're not obligated for all comers, for all patients to receive these kinds of dual antiplatelet therapies for a prolonged period of time. And let it be the patient in whom we decide, not the stent, what we should do for dual antiplatelet therapies. So I still would say we need to continue to strive for a better way to treat our patients when a metallic or even a bioabsorbable stent is placed in them, such that obligation for that patient to have to take dual antiplatelet therapies for a prolonged period of time is reduced. And this could be a promise, but it's certainly not delivered that and was not designed to deliver that.
Dean, let me ask you here. You were obviously the co-principal investigator of the DAPT study, right. And you were the principal investigator of EVOLVE. And I think that those comments by Roxana are so important to how we think about dual antiplatelet therapy and treating our patients. How do you respond to those, and what evidence do we need?
Well founded. The Synergy stent, and I applaud Roxana's interest in continued iteration to improve our target lesion treatment, which is the stent. The improvement of the patient treatment, with respect to secondary prevention in patients with symptomatic atherosclerotic cardiovascular disease that have durable atherothrombotic risk, may or may not involve long-term dual antiplatelet therapy, whether it was charisma symptomatic, whether it was cure, PCI or not PCI, and whether it was the DAP trial. The reduction in myocardial infarction was less than half related to stent thrombosis at the end of the day. So there's a patient that we got to treat systemically, and there's also target lesions. And I think this evolution, to use the play on words, in EVOLVE, is to create a better target lesion treatment, theoretically, a device that should facilitate, expedite healing because of the limited duration of the polymer. There are OCT studies that show complete endothelial coverage in isolated cases within 2 months. So it's possible that this is a better target site. It may be better as far as the long-term risk of stent thrombosis, which we know is durable out even 30 months, correct? We saw it with bare metal and DES in the DAP trial. And then the issue of patient treatment, I think there'll be trials in the near future, Pegasus is one, that I think will help us put all these pieces of the puzzle together.
For the many people who are watching who have never put their hands on one of these stents and weren't an investigator in the trial, tell us how the stent would compare to the comparator stent in deliverability.
It's an offset peak-to-peak, 2 connectors between rings, so it's very flexible and conformable. It is a easy deliverable stent. It's very low profile, and I think it's so user-friendly that operators will choose this stent because it's going to make every case easier, not just the tough cases, but every case. It's a high-performance device. Hopefully, the outcomes for the patient, from their perspective, will be improved as well. But the only way that'll ever be proven, Rox, is adequately powered. That's like Spirit 4. You have to have 5,000 patients, and you have to, or more. In fact, with these stents, because the event rates are so low with the comparator, as you say, it might be 10 or 20,000 patients. And I don't know that those trials will be done, but hopefully we can maybe find a surrogate or some other reflection that the patient perspective outcomes are better, healing is better, maybe as a surrogate, with invasive imaging techniques. And the operator perspective, it's a great stent to put in.
And Roxana, I'll ask you, how do you put these results into the perspective from the standpoint of a practicing clinician?
Well, I think I remain hopeful that our field continues to evolve and that we are really in pursuit of the best therapies for our patients. And when you see this kind of incredible engineering that goes on to try to take away a durable polymer to a biodegradable one, and maybe in the next generation a completely bioabsorbable scaffold that we're looking forward to, and I think these are all parts of how we will evolve in interventional cardiology to enhance and improve outcomes. But I would come back again to the patient and to say that we still do need to find the very best therapies. And while we are very focused on the reduction of ischemic events, we should not expose patients to the harm of bleeding if they don't need that. And if there are ways that we can enhance and improve those, we really should move towards that direction.
Great. Well, I think it's been a terrific discussion about congratulations, Dean, on such a wonderfully conducted trial. I think we're about out of time here, so I'd like to thank you for joining us on EHJ Today, the Voice of Leaders.